floor, but wakes up after a couple of seconds. On her way to the emergency room, she tells the paramedics that she's aware of her heartbeat. Then comes Taylor, a 32-year-old female who is brought to the emergency room by her partner because she suddenly collapsed for a couple of minutes while cooking dinner. Taylor's now awake, and she tells you that right before collapsing, she was feeling dizzy and like her heart was racing, but now she's fine. They're both placed on different monitors. Melissa's heart rate is 200 beats per minute and regular, and this is Melissa's ECG. On the other hand, Taylor's heart rate is 80 beats per minute and regular, so everything seems fine. However, her ECG shows this. Alright, so both Melissa and Taylor have experienced palpitations and syncope, and their ECGs reveal they both have some form of arrhythmia. The best way to approach arrhythmias is to first know what a normal ECG looks like, and second, have a good classification system to narrow down the diagnosis. First, let's review the normal electrical conduction pathway in the heart and how it looks on an ECG. An ECG tracing specifically shows how the depolarization wave flows through the heart during each heartbeat. The normal electrical activity of the heart starts in the sinoatrial or SA node and is then conducted through the atrium, creating the P wave on ECG. From the atrium, electrical activity goes to the atrioventricular or AV node, after which it goes through the bundle of His. Then, the right and left branches of the bundle, and finally, through the Purkinje fibers, which deliver the current to the right and left ventricles. On an ECG, this will create the QRS complex, which represents the depolarization of the ventricles, and finally, the T wave, which represents the repolarization of the ventricles. To help identify an irregular rhythm, you can look at the morphology of the waveform, and make sure that there is a P wave before every QRS complex, and a QRS complex after every P wave. Now, let's take a look at the heart rate. The resting heart beats at a rate between 60 to 100 times per minute, and each of those beats starts off with depolarization of the sinoatrial node, and so we call it a normal sinus rhythm. For your exams, you should be able to figure out the heart rate on an ECG. To do that, you can count the number of boxes between R waves. Each small box represents 0.04 seconds, and each big box is 5 small boxes, so each big box is 0.2 seconds. One quick way to estimate the heart rate on an ECG is to remember that the heart rate is 300, 150, 100, 75, 60, or 50, depending on whether there's 1, 2, 3, 4, 5, or 6 boxes between R waves. It's important to know that there is normally a delay in conduction at the AV node and the bundle of His, which gives some time for ventricular filling before the ventricle contracts. On the ECG, this is represented by the PR interval, which should be less than 5 small boxes, or 200 milliseconds. Now, any disturbance in the rate, rhythm, site of origin, or conduction of the cardiac electrical activity is called an arrhythmia. Arrhythmias can be completely asymptomatic and be picked up incidentally on an ECG. Arrhythmias can also present with palpitations, which is an awareness of one's heartbeat. Additionally, they may alter cardiac output, causing individuals to present with signs of hypotension and decreased brain perfusion, like dizziness, altered mental status, or syncope. If an arrhythmia is really fast, the heart now demands more oxygen, and if oxygen supply is not met, then the myocardium suffers from ischemia, which presents as angina. In people with underlying heart disease, the sudden onset of an arrhythmia can precipitate acute heart failure. Finally, some arrhythmias may even cause sudden cardiac death. Now, arrhythmias can be classified into those originating from above the ventricles, so supraventricular arrhythmias, and those originating in the ventricles, so ventricular arrhythmias. In general, what's important to remember is that supraventricular arrhythmias have a narrow QRS complex because there's a rapid excitation of the ventricles, which means the arrhythmia is originating above or within the bundle of His. On the other hand, ventricular arrhythmias have a wide QRS complex because there's a slower spread of ventricular depolarization. The first type of supraventricular arrhythmia includes those with sinus origin. So first, there's sinus tachycardia, which is a heart rate above 100 with a regular rhythm and normal P waves before each QRS complex. It can be physiological, like during exercise, or pathological. Pathological sinus tachycardia happens when the heart needs to compensate for an acute decrease in stroke volume, like in acute heart failure, acute myocardial infarction, or pulmonary embolism. It can also result from any overwhelming activation of the sympathetic nervous system, like in hyperthyroidism or cocaine or amphetamine use. Now, the thing is that a fast heart rate decreases diastolic filling time, which actually further decreases the stroke volume. Additionally, over time, catecholamines are actually toxic to the myocytes, which results in a form of cardiomyopathy called tachycardia-induced cardiomyopathy, which is a super creative name. Okay, but on the other hand of the spectrum, we have sinus bradycardia. Keep in mind that this can be completely physiological in athletes who have a resting heart rate between 40 and 60, and it's also normal during sleep. Pathological causes of sinus bradycardia include hypothyroidism, anorexia nervosa, and inferior wall myocardial infarctions. Another high-yield cause of bradycardia is the Cushing reflex, which includes the characteristic triad of bradycardia, hypertension, and an irregular respiratory pattern. This reflex occurs as a consequence of increased intracranial pressure, which can manifest from a variety of pathologies like head trauma, strokes, and brain tumors. For your exams, note that Cushing triad may indicate impending brain herniation, and thus it is a medical emergency. Other causes of sinus bradycardia include a bunch of medications like beta blockers, calcium channel blockers, and opiates, in which case the solution is discontinuing the medication if possible. Acute sinus bradycardia can be treated with IV atropine, while chronic and severe cases might need a pacemaker. Another arrhythmia of sinus origin is, sinus arrhythmia. This arrhythmia can occur naturally during inspiration and expiration. See, during inspiration, the heart rate increases, and during expiration, it decreases. So on ECG, the rhythm may appear irregular, but it is in fact a normal variant. Finally, sinus arrest, or sinus exit block, occur when the sinus node fails to fire. What you need to know is that on an ECG, there is simply a flatline pause. Fortunately, if the sinus node can't press that reset button, somebody else, like the AV node or virtually any other myocardial cell, can take over. All right, now the second type of supraventricular arrhythmias are reentrant arrhythmias. In this type, electrical activity is literally trapped in a circular electric racetrack, altering normal conduction. To understand this, let's picture a single myocyte with two branches, triggering two adjoining pathways, 1 and 2. Under normal circumstances, electrical activity starts on the SA node and then travels from one myocyte to the other. Now, the wave of depolarization should go through both 1 and 2 at the same speed. But let's say pathway 2 is damaged during a myocardial infarction. Now that pathway 2 is slowed down, the wave of depolarization rushes through pathway 1 and then returns backwards through pathway 2. This creates an electrical loop that is now independent of the SA node, meaning it can pretty much run itself now. There are 3 must-know subtypes of reentrant supraventricular arrhythmias: paroxysmal supraventricular tachycardia, or PSVT, atrial flutter, and atrial fibrillation. PSVT is usually caused by a reentrant circuit that loops within the AV node, which is why it's also referred to as an AV nodal reentrant tachycardia. PSVT can happen in people with totally normal hearts and no history of cardiac disease. A clue to this can be recent consumption of things like alcohol and coffee. On the ECG, PSVT appears as a regular rhythm with a rate ranging between 150 and 250 beats per minute, and a narrow QRS complex. The key is the absence of normal P waves, which tells us that the SA node is no longer in control. Now, the reentrant circuit is within the AV node, meaning it can go from the AV node up towards the atria. Since it's going in the opposite direction, you may be able to see retrograde P waves. However, because the PSVT is super fast, these retrograde P waves are usually buried in the QRS complex, so you may or may not see them. PSVTs are classically treated with vagal maneuvers, like carotid massage. When the carotid artery is massaged, the carotid sinus is stimulated, which stimulates the vagus nerve to fire. This slows conduction through the AV node, which interrupts the reentrant circuit, effectively slowing the heart rate and terminating the arrhythmia. Now, if vagal maneuvers don't work, the next step for treatment is adenosine, and this is commonly tested. Adenosine rapidly acts in about 15 seconds, causing a decrease in AV node conduction. Keep in mind that its effect is blunted by theophylline and caffeine. Another important thing to remember are its side effects, which include facial flushing, hypotension, bronchospasm, and chest pain. Moving on, atrial flutter is usually caused by a reentrant circuit that runs around the annulus of the tricuspid valve. On ECG, this usually appears as a regular rhythm with an atrial heart rate ranging between 250 and 350 beats per minute. Now, because of this super fast atrial heart rate, the AV node cannot handle all these impulses coming at it. So some impulses get through, and some don't. This generates what's called an atrial ventricular conduction ratio, which is usually 2 to 1, meaning one impulse gets through to the ventricles and the next does not, and so on. So let's say the atrial heart rate is 300. The ventricular rate would then be 150. The AV conduction ratio can be 3 to 1 or even 4 to 1. Okay, so on ECG, the giveaway will be flutter waves, which are P waves that give off a sawtooth appearance. Now, because the reentrant circuit is not within the AV node like in PSVT, vagal maneuvers will not work here, simply because the vagus nerve isn't innervating where the arrhythmia started. Instead, medications or electrical cardioversion is required to keep atrial flutter under control, while definitive treatment can be done with catheter ablation. Okay, so in atrial flutter, there was a single reentrant circuit causing the problem. On the other hand, in atrial fibrillation, there are hundreds of reentrant circuits scattered around the atria. The most common risk factors are hypertension and coronary artery disease. Another interesting cause is the holiday heart syndrome, where atrial fibrillation occurs after binge drinking. Now, for your exams, remember that here, the atrial heart rate is really fast, going above 500 beats per minute. So on the ECG, no P waves are seen. The poor AV node is seriously overwhelmed now, so we don't even get an AV conduction ratio. Instead, the AV node allows impulses to pass in a random and unpredictable fashion. On the ECG, this typically appears as an irregularly irregular rhythm, which means the QRS complexes will have no pattern at all, with a ventricular rate usually ranging between 120 and 180 beats per minute. The name fibrillation implies that the atrial muscles are shaking uncontrollably, meaning there is no actual atrial contraction. Now, atrial contraction only contributes to about 10 to 20% of the cardiac output, but in an individual with a history of cardiac disease, that 20% might be crucial. Another high-yield fact is that the absence of a true contraction causes stasis of blood flow in the atrial compartment, and this increases the risk of clot formation, especially in the left atrial appendage. This clot can dislodge and travel into the systemic circulation, causing multiple potentially life-threatening pathologies like embolic strokes, acute limb ischemia, central retinal artery occlusion, or acute mesenteric ischemia. Therefore, individuals often need treatment with anticoagulants, in addition to treating the arrhythmia itself with medications like beta blockers and calcium channel blockers. Finally, some individuals can be treated with cardioversion. A third type of supraventricular arrhythmia is ectopic rhythms, in which electrical activity may originate from a place other than the sinus node. Basically, fastest one to fire gets to be the pacemaker of the heart. If any myocardial cell gets a bit ambitious and starts firing faster than the SA node, then it can overtake the SA node as the pacemaker of the heart. A type of supraventricular arrhythmia with ectopic origin is multifocal atrial tachycardia, or MAT, which usually results from multiple ectopic foci firing from the atrium. MAT is classically associated with lung disease like asthma or COPD, so be sure to look for that in the question stem. On ECG, this also appears as an irregularly irregular rhythm at a rate of around 100 to 200 beats per minute. However, unlike atrial fibrillation, P waves are present in MAT. But because the P waves are originating from multiple sites in the atrium, they often vary in shape, and so will the PR intervals. In order to diagnose MAT, you need to identify at least 3 different P wave morphologies on ECG. Now, before we wrap things up, we should talk about pre-excitation syndromes, which may ultimately lead to supraventricular arrhythmias, especially PSVT. In pre-excitation syndromes, there's an accessory pathway that acts as a shortcut to the normal electrical circuit, causing the ventricles to be excited earlier than usual. The most important pre-excitation syndrome is Wolff-Parkinson-White syndrome, or WPW. People with WPW are born with an additional conduction pathway between the atria and the ventricles called the bundle of Kent. The cause of WPW is most often unknown, whereas a few cases are inherited through an autosomal dominant mutation of the PRKAG2 gene, which helps regulate ion channels specific to cardiac tissue. The 3 major changes on ECG in WPW are shortening of the PR interval, widening of the QRS complex, and presence of a delta wave, which is an upward slurring of the initial portion of the QRS complex. The delta wave indicates that the ventricle is being activated earlier than it normally should. Now, most people remain asymptomatic despite having this classic ECG pattern, whereas a small number can develop arrhythmias that can manifest as palpitations, dizziness, syncope, and even sudden cardiac death. All right, as a quick recap, an arrhythmia is any disturbance in the rate, rhythm, site of origin, or conduction of the cardiac electrical impulse. Arrhythmias can be classified based on their origin into supraventricular arrhythmias, which have a narrow QRS complex, or ventricular arrhythmias, which have a wide QRS complex. Supraventricular arrhythmias can be of sinus origin. This includes sinus tachycardia, which is a heart rate above 100, with a regular rhythm and normal P waves before each QRS complex, and sinus arrhythmia, which is a normal phenomenon that reflects the changes in heart rate during inspiration and expiration. Supraventricular arrhythmias can also have a reentrant origin. This includes PSVT, a regular rhythm with a narrow QRS complex and an absence of normal P waves, atrial flutter, a regular rhythm with P waves that give off a sawtooth appearance, and atrial fibrillation, an irregularly irregular rhythm with no P waves. Finally, supraventricular arrhythmias can have an ectopic origin like multifocal atrial tachycardia, which is an irregularly irregular rhythm with present P waves. An important cause of supraventricular arrhythmias are pre-excitation syndromes, like Wolff-Parkinson-White syndrome, in which an accessory pathway acts as a shortcut that causes the ventricles to be excited earlier than usual. Okay, back to our cases. Both Melissa and Taylor's presentations describe syncope and palpitations, suggesting something is going on with their hearts. Based on Melissa's ECG, this is likely a paroxysmal supraventricular tachycardia, or PSVT. In her case, it was likely triggered by her consumption of alcohol and caffeine. After a carotid massage is performed, her ECG converts back to a normal sinus rhythm. On the other hand, Taylor's ECG shows a short PR interval and a wide QRS complex with an initial delta wave, which is the classic ECG pattern of Wolff-Parkinson-White syndrome.
Clint is a 19-year-old male that's brought to the emergency department for acute chest pain. Upon examination, you notice that his heart rate is really fast, about 170 beats per minute. He has a history of depression and is currently being treated with TCAs. He is otherwise healthy. A few minutes after arriving, Clint loses consciousness. His ECG shows this. Alright, so based on his presentation and ECG, Clint has some form of arrhythmia. The best way to approach arrhythmias is to 1. Know what a normal ECG looks like, and 2. Have a good classification system to narrow down the diagnosis. To help identify an irregular rhythm, you can look at the morphology of the waveform and make sure that there is a P wave before every QRS complex and a QRS complex after every P wave. Now let's look at the heart rate. The resting heart rate beats at a rate between 60 to 100 times per minute, and each of those beats starts off with depolarization of the sinoatrial node, and so we call it a normal sinus rhythm. It's also important to know that there is typically a delay in the conduction at the AV node and the bundle of His, which gives some time for ventricular filling before the ventricle contracts. On the ECG, this is represented by the PR interval, which should be less than 5 small boxes or 200 milliseconds. Now, any disturbance in the rate, rhythm, site of origin, or conduction of the cardiac electrical activity is called an arrhythmia. Arrhythmias could be completely asymptomatic and be picked up incidentally on an ECG. Arrhythmias can also present with palpitations, which is a sensation of your heart beating too hard or fast, fluttering, or skipping a beat. Additionally, they may alter cardiac output, causing individuals to present with signs of hypotension and decreased brain perfusion, like dizziness, altered mental status, or syncope. If an arrhythmia is really fast, the heart muscles now demand more oxygen, and if oxygen supply is not met, then the myocardium suffers from ischemia, which presents as angina. In people with underlying heart disease, the sudden onset of an arrhythmia can precipitate acute heart failure. Finally, some arrhythmias may also cause sudden cardiac death. Now, arrhythmias can be classified into those originating from above the ventricles, supraventricular arrhythmias, and those originating in the ventricles, so ventricular arrhythmias. In general, what's important to remember for your exams is that supraventricular arrhythmias have a narrow QRS complex because there's a rapid excitation of the ventricles, which means the arrhythmia is originating above or within the bundle of His. On the other hand, ventricular arrhythmias have a wide QRS complex because there's a slower spread of ventricular depolarization. Okay, now the two types of ventricular arrhythmias are ventricular tachycardia and ventricular fibrillation. Ventricular tachycardia, or VT for short, originates from an ectopic focus located in the ventricle. The two main subtypes are monomorphic and polymorphic ventricular tachycardia. On ECG, both appear as wide QRS complexes at a rate ranging between 120 and 200 beats per minute. Monomorphic means that all the QRS complexes look the same, and it's classically a complication of myocardial scarring due to acute myocardial infarction. On the other hand, polymorphic means the QRS complexes have different shapes in each beat, as they come from different areas of the ventricle. This may occur due to acute myocardial ischemia, causing the pacemaker cells to be stressed, and it's not associated with myocardial scarring. Another cause of polymorphic VT that is frequently tested in the exams is Brugada syndrome. This is a rare autosomal dominant condition characterized by genetic mutations hitting cardiac sodium channels. Now, the test question will typically describe a male of Asian descent, whose ECG pattern in V1 to V3 shows pseudo-right bundle branch block, with the widened QRS presenting an RSR configuration, as well as ST elevations. Now, some individuals affected may present this ECG pattern and yet be asymptomatic, while others may present symptoms like syncope. Regardless, they're all at risk of developing polymorphic VT and sudden cardiac death, so treatment is primarily focused around prevention with implantable cardioverter defibrillators. A specific and very dangerous type of polymorphic ventricular tachycardia is known as torsade de pointe, which is French for twisting of the points. This is because on ECG, the varied QRS complexes give off the appearance that they're twisting around the isoelectric baseline. For your exams, remember that torsade de pointe is associated with anything that prolongs the QT interval. This includes diseases with genetic mutations hitting ion channels, most often potassium ones. Examples of these diseases include Jervell and Lang-Nielsen syndrome, which also causes deafness, and Romano-Ward syndrome, which is not associated with deafness. A prolonged QT interval can also be due to electrolyte abnormalities, and especially hypokalemia, hypocalcemia, or hypomagnesemia. On your exams, look for clinical scenarios that may cause these electrolyte abnormalities, such as someone with diarrhea who loses tons of potassium in their stool and subsequently develops an arrhythmia. In addition, many medications can prolong the QT, and this is frequently tested. To help you remember them, think A, B, C, D, E, where A is antiarrhythmic, type 1A, 1C, and type 3. B is antibiotics, like macrolides. C is for antipsychotics, like haloperidol, olanzapine, and ziprasidone. D is for antidepressants, like tricyclic antidepressants. And finally, E for antiemetic, like ondansetron. Now, regardless of the cause, remember that torsade de pointe must be quickly treated with intravenous magnesium sulfate, as it can rapidly progress to ventricular fibrillation. In many cases, ventricular tachycardia can progress to ventricular fibrillation or VFib. High-yield triggers include acute myocardial infarction, heart failure, shock, hypoxemia, or hypercapnia. In ventricular fibrillation, the heart's muscle fibers start quivering because they're not contracting at the same time. On ECG, the whole PQRST pattern breaks down completely, and there are no actual QRS complexes, just random undulating waves. And it's important to be able to recognize this pattern since the situation is extremely dangerous. Essentially, the heart's not able to squeeze anymore, so there's no cardiac output. As a result, your body, especially your brain, isn't getting fresh oxygen. That's why ventricular fibrillation is one of the most common causes of sudden cardiac death, so it must be immediately treated with CPR and defibrillation. All right, as a quick recap, an arrhythmia is any disturbance in the rate, rhythm, site of origin, or conduction of the cardiac electrical impulse. Ventricular arrhythmias are those that originate within the ventricles and have a wide QRS complex on ECG. These two types of ventricular arrhythmias are ventricular tachycardia and ventricular fibrillation. Ventricular tachycardia can be monomorphic, meaning that all the QRS complexes look the same, or polymorphic, meaning the QRS complexes are different in each beat. A specific and very dangerous type of polymorphic ventricular tachycardia is torsade de pointe, which presents a twisting pattern of QRS complexes. This can rapidly progress to ventricular fibrillation, in which the whole PQRST breaks down completely and is the most common cause of sudden cardiac death. Okay, back to our case. Clint's presentation describes palpitations and chest pain followed by syncope, suggesting something is going on with his heart. On ECG, you see a twisting pattern of QRS complexes, typical of the torsade de pointe. It was probably triggered by the TCAs he takes to treat his depression. You immediately give intravenous magnesium sulfate, successfully saving Clint's life. Moving forward, Clint should stop TCAs and switch to another antidepressant.
Mikey is a 22-year-old male college student from Vermont who was sent to the emergency department after passing out. His vital signs show a heart rate of 40 beats per minute and a blood pressure of 90/50. On examination, there is an erythematous circular rash with central clearing. His friends mention that they recently went on a hiking trip. His ECG is as follows. Natasha is a 60-year-old female with chronic hypertension, diabetes, and peripheral vascular disease who comes to the emergency room complaining of sudden onset, squeezing, retrosternal chest pain accompanied by shortness of breath and sweating. Her ECG is as follows. On laboratory evaluation, her troponin levels are significantly elevated. All right, so the normal electrical activity of the heart starts in the sinoatrial, or SA node, located near the opening of the superior vena cava into the right atrium. Electrical activity is then conducted through the atrium to the atrioventricular, or AV node, after which it goes through the bundle of His, then the right and left branches of the bundle, and finally through the Purkinje fibers, which deliver the current to the right and left ventricles. Now, normally there's a delay in conduction at the AV node and the bundle of His, which gives some time for ventricular filling before the ventricle contracts. A heart block, or AV block, occurs when conduction is delayed for too long at the AV node or the bundle of His. Also, electrical activity may be blocked at the level of the bundle branches, which are called bundle branch blocks. Okay, on the ECG, the normal delay in the AV node is represented by the PR interval, which is normally less than 5 small boxes, or 200 milliseconds. There are 3 main types of AV block. First degree AV block is technically not really a block, it's more of a delay. Every single atrial impulse eventually makes it to the ventricles. The high yield concept here is that the only abnormality is a prolonged PR interval, and it's usually asymptomatic, so it doesn't require treatment. Second degree AV block has two subtypes, Mobitz 1 and Mobitz 2. In Mobitz 1, each atrial impulse encounters a longer and longer delay until one of them doesn't make it through to the ventricles. The high yield concept here is that on the ECG, this is reflected as the PR interval getting progressively longer and longer until all of a sudden the heart drops a beat. Like in Mobitz 1, the heart also drops a beat in Mobitz 2, except this time conduction through the AV node is all or nothing. Either the atrial impulse goes through with no delay, or it doesn't go through at all. Basically, there's no progressive prolongation of the PR interval in Mobitz 2. On the ECG, Mobitz 2 shows a couple of normal PR intervals followed by a dropped beat. Also, like first degree AV block, Mobitz 1 is usually benign and doesn't require treatment unless it's causing symptoms. On the other hand, Mobitz 2 can be dangerous and may result in severe bradycardia and decreased cardiac output. Therefore, it requires treatment with a pacemaker. Now, Mobitz 2 blocks can sometimes progress to our next type, the dangerous third degree AV block. In this type, none of the electrical impulses are conducted through the AV node, and that's why it's also called complete heart block. Now, remember that all cardiomyocytes are capable of starting their own electrical activity, a property called automaticity. So in third degree AV block, the ventricles recognize that they're not getting any impulses and respond by generating their own electrical rhythm called a ventricular escape rhythm, just to hang on to dear life. Because the atria and the ventricles each have their own pacemakers, they now contract independent of one another, which is called AV dissociation. This desynchronization of the heart chambers can reduce cardiac output dramatically, leading to syncope or even sudden cardiac death. On the ECG, the P waves and QRS complexes have nothing to do with each other, each appearing at their own rates. The atrial rate is 60 to 100 beats per minute, whereas the ventricular rate usually ranges between 30 and 45 beats per minute. Because of how dangerous third-degree blocks are, anyone diagnosed with it needs a pacemaker. All right, so a lot of things can cause the three types of AV block. A myocardial infarction may involve the conduction pathway, causing a delay in electrical conduction. This is especially common in right coronary artery occlusion because it gives off a small branch that supplies the AV node. On the exam, a clue towards right coronary artery occlusion would be a case of inferior wall myocardial infarction, indicated by elevation of the ST segments in leads 2, 3, and AVF. Also, electrolyte disturbances like hyperkalemia can alter the membrane potential. Then there are external causes like Lyme disease, medications such as beta blockers, calcium channel blockers, adenosine, amiodarone, and digoxin. For your exams, remember that Lyme disease is typically associated with third-degree AV block. Interestingly, congenital heart block is a complication of neonatal lupus, which could also show up on your exam. Here, the maternal autoantibodies, called anti-Rho and anti-La antibodies, cross the placenta and attack the conduction system. AV block may also be a normal variant in some circumstances, like in athletes. The next type of conduction block occurs in either the left or right branches of the bundle of His, and are called bundle branch blocks. In normal ventricular depolarization, the QRS complexes are narrow, that is, less than 3 small boxes or 120 milliseconds. As a general rule of thumb, all bundle branch blocks cause the QRS complexes to appear wide. This is because we're delaying the time for complete depolarization of both ventricles. In right bundle branch block, or RBBB, the high yield fact to remember is that the QRS complexes in the right-sided chest leads V1, V2, and V3 show an RSR configuration. This means a pronounced R wave, followed by a deep S wave, and then another R wave. This gives the QRS complex the appearance of rabbit ears, or the capital letter M. To remember this, think RBBB equals rabbit ears in the right-sided chest leads. Causes of RBBB include right ventricular hypertrophy, right heart failure, and pulmonary embolism. These causes are due to the right heart not functioning normally, so there is delayed conduction through the heart tissue. Also, for unknown reasons, RBBB can be present in normal hearts, possibly due to deposition of fibrous tissue that interrupts the conduction pathway. Now, let's look at left bundle branch block, or LBBB. Similar to RBBB, the QRS complexes will be wide because of the delay in ventricular depolarization. In leads 1, AVL, V5, and V6, tall R waves are present, and in lead V1, broad, deep S waves are characteristic. Additionally, there may be ST segment depression and T wave inversion. Now, unlike RBBB, LBBB never occurs in normal hearts, so there's always something wrong. Examples include hypertension, ischemia, dilated cardiomyopathy, and aortic stenosis. Similar to the causes of RBBB, these disorders affect the left ventricle, causing a delay in conduction through the cardiac tissue. Importantly, a new LBBB in an individual presenting with chest pain may be a sign of myocardial infarction. All right, as a quick recap. AV node block is divided into 3 major subtypes. First degree AV block is simply a prolonged PR interval. Second degree AV block has 2 subtypes, Mobitz 1 and Mobitz 2. Mobitz 1 is characterized by a progressively prolonged PR interval followed by a dropped beat. Mobitz 2 has a normal PR interval followed by a sudden dropped beat. In third degree AV block, there is no relationship between the P waves and QRS complexes, a phenomenon known as AV dissociation. Bundle branch blocks also have a wide QRS complex. In RBBB, an RSR complex, or rabbit ears, appears in the right-sided precordial leads. In LBBB, there are tall R waves in leads 1, AVL, V5, and V6, as well as deep S waves in lead V1. All right, back to our cases. Mikey is presenting with syncope, so let's take a look at his ECG. We see that there is no relationship between the P waves and the QRS complexes. Each one is appearing at their own rate. This indicates a third-degree AV block. Considering he recently went on a hiking trip in Vermont and he's got a bullseye rash, it's likely that the cause of his AV block is Lyme disease. Mikey was treated with intravenous antibiotics and is now off planning his next hike. Okay, on to Natasha's ECG. First, we see that the QRS complexes are wide in all the leads, but that's not really specific for anything. Looking closer at leads 1, AVL, and V6, we see those characteristic tall R waves. Also, lead V1 shows a broad S wave. These characteristics are indicative of left bundle branch block. Considering Natasha is presenting with chest pain and her troponin levels are elevated, this new LBB may be indicative of an acute myocardial infarction.
Coronary artery disease can lead to myocardial ischemia, which is when the myocardium isn't getting a sufficient blood supply, so there isn't enough oxygen to meet the heart's demands. And coronary artery disease is characterized by a type of chest pain called angina pectoris, which can be due to either vasospastic disease or atherosclerotic disease. Vasospastic disease, also called Prinzmetal angina, is when, for unclear reasons, there's transient vasoconstriction of a coronary artery, leading to transient ischemia. These attacks generally happen at rest, during the night or early morning, and happen in clusters. Atherosclerotic disease is when a coronary artery narrows due to buildup of atherosclerotic plaque, and it can be further divided into stable angina, unstable angina, and myocardial infarction. Unstable angina and myocardial infarction are collectively called acute coronary syndrome. Patients with stable angina don't feel pain at rest, but they do feel chest pain during intense physical exercise, because that's when the myocardium has increased oxygen demand, which leads to transient or demand ischemia. The chest pain stops when the exercise stops, so these patients often just rest rather than going to the emergency department or ED. Now, angina is considered unstable if it presents at rest, or if it becomes more frequent, lasts longer, or happens with less exertion than previous episodes of angina. In unstable angina, there's prolonged myocardial ischemia, but there's no myocardial cell death yet, so it's not a myocardial infarction. But if it's not taken care of promptly, the ischemia can get prolonged and can lead to myocardial infarction, which is life-threatening. When a patient comes into the ED with acute chest pain, a number of things have to be done within 10 minutes to confirm or exclude a myocardial ischemia. The differential diagnosis includes gastroesophageal reflux, pulmonary embolism, aortic dissection, a pneumonia, or a panic attack. The first step is to check the airway, breathing, and circulation, perform a quick physical exam, and attach cardiac and oxygen saturation monitors. And supplemental oxygen should be given if the oxygen level dips below 90%, and supplemental assisted ventilation should be given if the oxygen level dips below 80%. Emergency resuscitation equipment should be nearby, including a defibrillator and airway equipment, just in case the patient goes into cardiac arrest. All patients with suspected myocardial ischemia should be given 325 milligrams of aspirin, unless there's a contraindication, like a history of an anaphylactic reaction or if they've already received it. The aspirin can be given orally or as a rectal suppository. In the meantime, IV access should be obtained, and blood should be drawn for initial laboratory work. including a CBC, electrolytes, creatinine and blood urea nitrogen, coagulation factors, lipids, and most importantly, cardiac biomarkers of acute myocardial damage, including a troponin T and I, which are essential for diagnosing a myocardial infarction. Other cardiac biomarkers like creatine kinase or lactate dehydrogenase are less sensitive and specific than cardiac troponin. So the current guidelines recommend cardiac troponin as the only cardiac biomarker that should be measured in a patient with suspected myocardial infarction. Troponins are generally found inside cardiomyocytes, so when they die, the biomarkers are released into the bloodstream, so their blood levels rise. But it can take up to 6 hours for the elevation of cardiac biomarkers to be detectable, so troponin levels should be checked initially and then again after 6 hours. If troponins are negative, it might be that the patient is having unstable angina, a short attack of Prinzmetal angina, or a non-cardiac cause of chest pain. If troponins are positive, that means there's cardiomyocyte death, which means that it's a myocardial infarction. Next, it's important to get a clear history of the chest pain, and the acronym OPQRST can help. O stands for onset, which is usually sudden and at rest, but might also happen while exercising. P stands for provocation, so which activities provoke pain, and palliation, so which activities alleviate pain. Generally speaking, angina pectoris doesn't improve or worsen with respiration or position. Q stands for quality, which might be described as a pressure, heaviness, tightness, fullness, or squeezing. R stands for radiation, which is most often to the neck, jaw, and left arm. S stands for sight, which typically is substernal or in the left chest, and the pain is usually diffuse and difficult to localize. If a person can point to the site of pain with a single finger, it's less likely due to cardiac ischemia. Finally, T stands for time course, which typically lasts over 30 minutes. Myocardial ischemia can also cause dyspnea, palpitations, nausea, and increased sweating. And some important risk factors include being over 55 years old, being male, hypertension, hypercholesterolemia, diabetes mellitus, smoking, obesity, and family history of first-degree relatives with premature coronary artery disease, so males before the age of 55 years and females before the age of 65. Also, women, older adults, and patients with diabetes often have atypical presentations, like just dyspnea, epigastric pain or discomfort, syncope, or sudden death from cardiac arrest. In individuals having myocardial ischemia, so those with unstable angina and myocardial infarction, as well as Prinzmetal angina, nitrates should be used immediately to help widen the coronary arteries and help increase blood flow to the heart, which should relieve the pain and decrease the blood pressure. 3 sublingual doses of 0.4 milligrams of nitrates are generally given, 1 every 5 minutes. If the patient has Prinzmetal angina, nitrates will lead to an immediate and full recovery, so nitrates help with both diagnosis and management. And if the patient has unstable angina or a myocardial infarction, then pain and blood pressure should improve. So if there's really no improvement at all, then intravenous nitrates might be needed. Nitrates are contraindicated in cases of hypotension, myocardial infarction of the right ventricle, and recent use of PDE5 inhibitors, like sildenafil, because in these situations, nitrates can cause really severe hypotension. Additionally, some patients with ongoing chest pain or tachycardia should be given beta blockers to lessen cardiac demand. And if the patient is hypertensive, intravenous beta blockers can be used. Beta blockers are contraindicated in Prinzmetal angina because they can worsen the coronary vasoconstriction. They're also contraindicated in bradycardia, cardiogenic shock, and acute decompensated heart failure, all of which can worsen with beta blockers. Beta blockers are also contraindicated in cocaine-related acute coronary syndrome. That's because cocaine triggers a huge release of sympathomimetic amines. And if the beta receptors are blocked by the beta blockers, then those sympathomimetic amines end up binding to alpha receptors, causing severe coronary vasoconstriction. Now, patients with underlying heart failure must be given an intravenous loop diuretic like furosemide. In addition, patients with severe and persistent chest pain can be given intravenous morphine sulfate at an initial dose of 2 to 4 milligrams, repeated in 5 to 15-minute intervals. Basically, every patient suspected of having myocardial ischemia should get a standard 12-lead electrocardiogram, or ECG, within 10 minutes of arrival to an ED. And the initial ECG is often not diagnostic, so it should be repeated at 5 to 10-minute intervals if there is high suspicion for myocardial ischemia. In addition to making sure that there's a normal sinus rhythm, if we suspect myocardial ischemia, the most important thing is to check the ST segment. In healthy individuals, the normal ST segment has a slight upward concavity. In stable angina, the ST segment is normal, and in unstable angina, the ST segment is generally normal or depressed. Now, myocardial infarctions can be divided into non-ST segment elevation myocardial infarction, or NSTEMI, and ST segment elevation myocardial infarction, or STEMI. In an NSTEMI, the ST segment might be normal, but there might be an ST depression that's more than 0.5 millimeters or 0.05 millivolts, in 2 or more contiguous leads, or deep T-wave inversions above 1 millimeter or 0.1 millivolts. STEMI is when there's an ST elevation above 1 millimeter or 0.1 millivolts in 2 or more contiguous leads or new left bundle branch block. ST elevation happens when there's full thickness involvement of the myocardium. The location of a myocardial infarction can be determined by which ECG leads show ST elevation. In anterior wall ischemia, ST elevation will show up in the precordial leads, so V1 to V6. In anteroseptal ischemia, it'll show up in leads V1 to V3. Apical or lateral ischemia will show up in leads AVL and 1, and leads V4 to V6. Inferior wall ischemia will show up in leads 2, 3, and AVF. Right ventricular ischemia will show up in the right-sided precordial leads, which can be obtained by placing leads V1 to V6 in a mirror image position on the right side of the chest. And posterior wall ischemia will show in the septal precordial leads, so V1 and V2, and posterior precordial leads. Now, ST depression in V1 and V2 is also important, because these anterior leads mirror the ST elevation that might be happening in the posterior precordial leads V7, V8, and V9, which are not included in the standard 12-lead ECG. In other words, they represent a posterior STEMI, which needs to be treated as a STEMI and not like an NSTEMI. Now, Prinz metal angina might present with a normal or depressed ST segment in short attacks, or ST elevation in long attacks. However, the ECG changes can only be found during the attack, so to spot it, the patient should be put on Holter monitoring, which is a device that records ECG tracings for 24 hours or longer. Now, if there's no evidence of ischemia, you should do further testing in the ED setting, such as a stress test, which measures the heart's ability to respond to external stress in a controlled clinical environment. The stress response is induced by exercise or by drug stimulation with dobutamine. Cardiac stress tests compares the coronary circulation while the patient is at rest with the coronary circulation during physical exertion. A negative stress test means that the coronary arteries are able to dilate and provide more blood to the myocardium when needed, and that the chest pain is likely from a non-cardiac cause. A positive stress test means that the coronary arteries aren't able to dilate, and that the chest pain is likely due to unstable angina, which is managed the same way as an NSTEMI. So a patient with unstable angina or NSTEMI needs urgent treatment with antithrombotic therapy, both oral antiplatelet therapy with a P2Y12 inhibitor like clopidogrel, in addition to aspirin, and anticoagulant therapy with heparin to prevent thrombosis or embolism from an ulcerated plaque. After that, individuals at high risk of short-term adverse events should be identified. Those are ones with hemodynamic instability or cardiogenic shock, left ventricular dysfunction or heart failure, recurrent or persistent rest angina despite intensive medical therapy, new or worsening mitral regurgitation, new ventricular septal defect, or sustained ventricular arrhythmias. These high-risk patients should get immediate coronary angiography, as well as revascularization, which is also called reperfusion therapy, to restore coronary perfusion. Low-risk patients should get coronary angiography and reperfusion therapy within 12 hours of symptoms. Patients who lack these features should undergo early risk stratification to identify individuals at high risk of long-term adverse events, who therefore should be treated with an early invasive strategy as well. Two common scoring systems are the TIMI risk score and the GRACE score. The TIMI score considers 7 factors, each accounting for 1 point in the final score. Age over 65, at least 3 risk factors for coronary artery disease, prior coronary artery stenosis of 50% or more, ST depression, at least 2 anginal events in the prior 24 hours, elevated serum cardiac biomarkers, and use of aspirin in the prior 7 days. The GRACE score considers 8 factors: age, systolic blood pressure, heart rate, ST segment deviation, so either elevation or depression, cardiac arrest at admission, serum creatinine concentration, serum cardiac biomarkers, and Caleb class. The highest total possible score is 363. Now, the Caleb classification takes into account physical examination findings like rales or crackles in the lungs, an S3 heart sound, elevated jugular venous pressure, acute pulmonary edema, cardiogenic shock or hypotension, oliguria, cyanosis, or sweating, as well as the development of heart failure. Patients at high risk using the GRACE risk scores are usually referred for coronary angiography and reperfusion therapy. Specifically, if their GRACE score is higher than 140, they're referred for early therapy, so within 24 hours from diagnosis. And if their GRACE score is between 109 and 140, they're referred for delayed therapy, so within 72 hours from diagnosis. Lower risk patients might get non-invasive testing like a stress test to determine their need for coronary angiography and reperfusion therapy. Moving on, patients with STEMI need immediate, so within 2 hours from diagnosis, coronary angiography and reperfusion therapy, ideally within 12 hours from symptom onset. The 2 ways to do reperfusion therapy are mechanical reperfusion with primary percutaneous coronary intervention, or PCI, which usually includes the insertion of a stent to keep vessels open and is strongly preferred. The alternative approach is to do reperfusion therapy using medications, sometimes called pharmacological reperfusion, using fibrinolytics. Typically, that's done when primary PCI can't be done within 2 hours of arrival to the ED. If more than 12 hours have passed since symptom onset, reperfusion should generally not be performed, but emergent PCI might be done for patients with ongoing ischemia or those at high risk of death. After reperfusion therapy, or in cases where it wasn't done, oral antiplatelet therapy with aspirin and a P2Y12 inhibitor, plus anticoagulant therapy with heparin is given to patients. All right, as a quick recap. Coronary artery disease can be due to either vasospastic disease, so Prinzmetal angina, or atherosclerotic disease, so stable angina, unstable angina, and myocardial infarction, which is further divided into NSTEMI and STEMI. Patients presenting to the ED with suspected myocardial ischemia should be given aspirin, nitrates, morphine, get troponin sent, and get an ECG looking for ST segment changes, all within 10 minutes. In Prinzmetal angina, there's immediate and full recovery with nitrates. If the ST segment is normal or depressed and troponins are negative, it's unstable angina. If the ST segment is normal or depressed and troponins are positive, it's NSTEMI. If the ST segment is elevated, it's a STEMI. So you don't need to wait for the results of the troponins, but they'd definitely be elevated. Unstable angina and NSTEMI are managed with a combination of antiplatelet and anticoagulation therapies, and a risk factor assessment is done to decide if they need immediate coronary angiography and reperfusion therapy. STEMI is managed with emergency reperfusion therapy, either with PCI or systemic thrombolysis. And after reperfusion therapy, patients are given a combination of antiplatelet and anticoagulation therapies.